Module 5, Lecture 3, Hypertensive Emergencies and Infectious Diseases of the Heart. We're going to define hypertensive emergencies, identify hypertensive urgency, identify signs and symptoms of a hypertensive emergency, explain the treatment approach for a hypertensive emergency. We're going to explain the etiology, history, physical findings, and management of endocarditis, pericarditis, myocarditis, and other infectious diseases of the heart. So a hypertensive emergency. Hypertension is a systolic blood pressure exceeding 140 millimeters of mercury or diastolic pressure exceeding 90 millimeters of mercury. Modifiable risk factor includes stroke, AMI, heart failure, dementia, peripheral vascular disease, aortic dissection, or end-stage renal disease. It's called the silent killer because it usually produces no signs or symptoms, and it damages the heart, the brain, the eyes, the blood vessels, and kidneys. A hypertensive emergency is defined as an acute elevation of blood pressure to 180 over 120 millimeters of mercury or higher with evidence of end organ damage. A common cause is failure to take blood pressure medications or other treatments as prescribed. Usually occurs in patients with a history of hypertension. A hypertensive urgency exists when there is an acute elevation of blood pressure to 180 over 120 millimeters of mercury or higher without signs or symptoms of end organ damage. Most cases result from advanced atherosclerosis or arteriosclerosis. Many conditions such as anxiety or pain can briefly elevate a person's blood pressure. Single reading does not constitute hypertension. Suggests a patient had their blood pressure rechecked a couple times in the following weeks. Persistent elevation in diastolic pressure is indicative of hypertensive disease, which can significantly shorten a lifespan, predispose a person to other medical conditions including renal damage, stroke, heart failure. Hypertensive emergencies require rapid lowering of blood pressure to prevent or limit organ damage, and it may cause acute renal failure, AMI, stroke, or death within a few hours if left untreated. Hypertensive emergencies often develop rapidly. Neurologic signs and symptoms include headache, blurred vision or sudden blindness, aphasia, numbness or weakness. Mental status changes ranging from confusion to unresponsiveness. Widespread neuromuscular irritability. Cardiovascular signs and symptoms include chest pain or tightness, shortness of breath, palpitations, dysrhythmias, signs of heart failure, or sudden severe chest or upper back pain that may indicate aortic dissection. Additional signs and symptoms decrease or absence of urine output, nausea, vomiting, ringing in the ears, nosebleed, or muscle cramps. Peripheral pulses may feel strong or bounding. Seizures, signs of heart failure, or signs consistent with AMI may be present. Ask the patient about what medications they take and if they take them as they are prescribed. Provide supportive care, administer oxygen if needed, establish an IV line, apply the cardiac monitor and pulse oximeter, provide care according to local protocols, which may include the administration of beta blockers, which is usually what the acute treatment would be. If a long transport time is unavoidable, paramedics may need to initiate drug therapy in the field. Like I mentioned, labetalol is a beta blocker, which decreases overall peripheral vascular resistance and prevents reflex tachycardia. Labetalol is an alpha and beta blocking drug, which properties decrease what I just mentioned, the overall peripheral vascular resistance. Keep the patient supine if tolerated. Measure the blood pressure at least every 2 to 3 minutes. Stop the infusion when the blood pressure has fallen to the target level. A patient with a hypertensive emergency requires transport to the closest appropriate facility. If the patient refuses care, you should repeatedly urge the patient to accept assistance. You need to make sure that you document very well and consider contact medical direction for advice. Endocarditis. Endocarditis is an infectious disease that affects the inner lining of the heart. It's characterized by inflammation of the endocardium. Highest risk in patients with mitral or aortic valve disease, prosthetic heart valves, or congenital heart disease. Right-sided endocarditis affects the tricuspid and pulmonary valves. This is often seen in IV drug users. Patients with infected central venous catheters, dialysis shunts, or transvenous pacing wires. On your assessment, symptoms include fever, chills, headache, loss of appetite, weight loss, muscle and joint aches and pains, night sweats, shortness of breath, cough, heart failure, or you may also see ECG changes such as prolonged PRI, third-degree AV block, or a left bundle branch block. Care is typically supportive with these patients. Establish an IV line, continue cardiac monitoring, and transport to the hospital. Pericarditis is acute inflammation of the pericardium. It's often caused by either a viral, bacterial, or occasionally a fungal infection. In many cases, no cause can be identified. Ask the patient about recent flu-like symptoms. The patient may relate a history of recent upper respiratory infection. Chest discomfort is the most common symptom of pericarditis. Sharp stabbing chest pain that is made worse by deep inspiration, coughing, or lying flat. Pain decreases when sitting up and forward. Listen to heart sounds, and this may reveal a pericardial friction rub. The sign's not always present. Typical signs include fever, tachycardia, tachypnea, pale skin, JVD, normal breath sounds unless other conditions exist, and you may even see ST segment elevation in multiple ECG leads. Pre-hospital care is supportive. Pericarditis is usually treated with non-steroidal anti-inflammatory drugs. Viral pericarditis usually resolves on its own. Bacterial pericarditis will be treated with antibiotics, and fungal pericarditis would be treated with antifungal medication. Myocarditis is inflammation of the myocardium. It's usually benign and self-limiting. It could cause other issues that impair the heart's ability to pump, such as right ventricular failure, left ventricular failure, or some dysrhythmias. And it can be caused by bacteria, viruses, parasites, heart transplant rejection, exposure to chemical poisons, or other unknown factors. Assessment is going to be very similar. Most cases are associated with flu-like symptoms for which the patient does not seek care. Fatigue, decreased appetite, mild shortness of breath, joint and muscle aches and pains, fever, palpitations, chest discomfort, often a sharp stabbing pain in the center of the chest, tachycardia, tachypnea, atrial or ventricular dysrhythmias, right bundle branch block, or left bundle branch block. Sometimes, if heart failure is present, you may hear crackles or you may see ascites. The ECG may show low voltage QRS complexes, pathologic Q waves, and or non-specific ST segment and T wave abnormalities. Differential diagnoses to consider for myocarditis include ACS, aortic distension, esophageal perforation, rupture or tear, heart failure, Kawasaki disease, pneumonia, or pulmonary disease. And treatment is going to be supportive. Other infectious diseases include rheumatic fever, which is an inflammatory disease caused by streptococcal bacteria. It causes aortic or mitral valve stenosis, leading to heart complications. This will be supportive pre-hospital care. And scarlet fever. Scarlet fever is caused by the Streptococcus pyogenes bacterium. Signs and symptoms include sore throat, fever, rash, strawberry tongue, as you see in this image here. Patients younger than 1 year are at greatest risk, and this is usually treated with antibiotics, and pre-hospital care is supportive.